glaucoma is probably the most abused machine in ophthalmology. I don't know how many of you will agree with this statement, but Sanjay Asrani, come here, sir. You are going to talk first on using OCT in glaucoma, strategy and pitfalls. So this will give you a clear idea how to incorporate this in glaucoma practice. He's a professor of ophthalmology in Duke University, Dr. Sanjay.
Thank you, Barunji. Thank you very much for your kind invitation, and to the co-chairs as well. Yes, the OCT, I agree, is possibly the most used and the most abused machine. The fun starts when you are training fellows and the OCT machine doesn't turn on that day. And then suddenly they have to rely on their clinical skills, which is what has been lost with the advent of the OCT. So let's look at some strategies and pitfalls. These are my disclosures. I do receive instruments on loan from Heidelberg Engineering to test them out and to test their strategies. Establishing a diagnosis. We look at the various parts of the OCT, and most individuals, whether in training or even out of training, will typically look at the red-green type of strategy and calculations, and I keep telling them that that is not where we should look at. We should not look at the average thickness measurements of the quadrants, but we should look at this, the least attractive part of the OCT report, which shows you the asymmetry between the right and the left eye. And since asymmetry is a hallmark of glaucoma, looking for the asymmetry will tell you where the glaucoma damage is. One must not ignore, in looking at these reports, the red-free or the SLO image, which shows you the nerve fiber layer defect, and also the raw scan that shows you whether the segmentation has been correctly done or not. The cup to disc asymmetry is one of the hallmarks of diagnosis of glaucoma. The problem is that when we are doing clinical examinations, we look at one disc, we cross over the nose, and when we look at the other disc, we have forgotten what the first disc looked like, because there are so many thoughts that went through our head, and we forgot. The OCT report is the only place that you can actually see the two discs of the individual side by side. And you can see that this disc is much bigger than this disc. And no wonder this patient is a glaucoma suspect, because there is a cup to disc asymmetry because of the disc size asymmetry. And as you can see, there is extreme symmetry in the nerve fiber layer thickness of this patient. Now, this is just to show you how we typically use OCT to diagnose glaucoma. We look at the nerve fiber layer thickness measurement, and we look at where there is a pinch. If it is early glaucoma, almost always the loss is in the superotemporal or the inferotemporal areas. And you can see where it dips into the abnormal, but you have to make sure that it is corresponding to that. And then, of course, the average thickness will be lower. But this has to correspond to a loss of the macular thickness as well. Whether you do total macular thickness, that is total retinal thickness, or you do GCC, whichever you do, it has to be corresponding, because it is the same structure. It is the loss of the ganglion cells here that actually create the temporal raphe sign that Professor Kehoe Park has shared with us. This loss that causes this loss of the nerve fiber layer and ganglion cells, that is causing a small field defect up in this region. You can also see it on a color picture of the optic nerve. And then there are normative databases available that show you the loss of nerve fiber layer, the loss of the ganglion cells. But mind you, they give you only a normative database in this circle. but they miss out on this entire region. This circle, if you find abnormalities, you typically find them in low pressure glaucoma patients because it is more paracentral in location. Whereas high pressure glaucoma, you can see them much more in the periphery. I'd like to share some pitfalls also. There are certain cases that highlight the principles of OCT. For example, this is a patient that looks exactly like glaucoma. There is a inferior arcuate defect. There is a loss superiorly in the left eye of the nerve fiber layer, a corresponding loss of the macular thickness. But what is unusual about this is that there is a temporal loss in the patient. A temporal RNFL loss or decrease should not be there in early to moderate glaucoma. Yes, in advanced glaucoma there could be, but not in early to moderate. So whenever you see temporal loss that is greater than the superior and inferior loss, think neurological. And yeah, we did the first blood test on this patient and it turned out to be neurosyphilis. That was active. When you see a horizontal cutoff of the visual field, like an altitudinal field defect, and a horizontal cut, that is loss here but complete normality here, loss up here but complete normality in the lower half, it is a vascular event. So you have to now realize that this something happened, either a branch retinal artery occlusion or a non-arthritic ischemic optic neuropathy. Since I said asymmetry is the hallmark of glaucoma, if you see symmetry, then there is a high chance it may not be glaucoma. So this is a case of extreme symmetry. You see there is a loss superiorly of the macular thickness, of the nerve fiber layer thickness, extreme symmetry of the field defect. This patient, unfortunately, was on 4 glaucoma medications for normal pressure glaucoma at age 22. But the extreme symmetry gave it away that it is segmental disc hypoplasia that is actually causing this. Now, having said that, when you see extreme asymmetry like this, you see the severe temporal loss, severe nasal loss, and this is real. This is not a segmentation error. You must think of homonymous hemianopia. And you can confirm that on the ganglion cell or the retinal thickness. You can see one side is lost. Mind you, if you should see a visual field defect of homonymous hemianopia, but don't see the changes on the RNFL, that patient is having a fast-growing tumor. That means structural has not yet been affected, function has been affected, that's an emergency. This is homonymous hemianopia, and then this one is again extreme asymmetry, and that's because of cancer-associated retinopathy. Glaucoma progression, you can see that on the cirrus with 2 baseline images from which the next subsequent images are subtracted. You can see the slope. You can see that in the cup to disc ratio as well as in the nerve fiber layer, and you can see where the probability is. And you can also see in color coding of the nerve fiber layer thickness. With the spectralis, you see that there is nerve fiber layer thinning, as is happening here with the yellow arrows, and the blue arrow shows you where the nerve fiber layer thinning has happened. And corresponding to that, you see that on the macular thickness. On the baseline, which is the top image, and then the subsequent visit and the subtraction is shown here, which shows you 20 to 30 micron difference. This is a case of false progression. You can see how this patient is gradually losing nerve fiber layer thickness. But when you look carefully, all that has happened is a posterior vitreous separation. So the nerve fiber layer appears thinner, and therefore there is no macular change. And this is an example of false progression and masking of progression in the same eye. See where the yellow arrow is? And you can see that there is an actual decrease in the nerve fiber layer thickness inferotemporally. But inferotemporally, the slope is flat. Superotemporally, where there is an epiretinal membrane, it is showing actually a drop in thickness because the epiretinal membrane is gradually lifting off. So here is false progression and masking of progression. And a last couple of slides on, this is uveitis causing growth of nerve fiber layer thickness, edema, and you can see that when you're treating uveitis, that the RNFL thickness keeps decreasing, cupping keeps increasing, but the field doesn't change. And then there is this high risk glaucoma progression where you can see a change in the temporal area, very close to the fovea, that will affect inferotemporal visual field losses. We'll skip a few of these and go to establishing a diagnosis. We all thought, at least I thought, when you see a nerve fiber layer defect, when you see a ganglion cell loss, when you see a field defect, it's glaucoma. Well, it may not be, because as you can see with this patient with multiple nerve fiber layer defects, look at the cup. The cup is hardly there. There is no cupping. Why? Because all these nerve fiber layer defects were caused by cotton wool spots, which were never detected. So we are telling you that all RNFL loss is not glaucoma. For example, this patient who developed a field defect, a nerve fiber layer defect, macular thickness loss, but it was because of a cotton wool spot. So decrease of global nerve fiber layer is not specific to glaucoma, can occur in other non-glaucomatous conditions. The commonest cause of decrease of the nerve fiber layer is due to posterior vitreous separation. Focus on the infero and superotemporal sectors. Artifacts are present in over 1/3 of the scans. Looking at trend-based versus event-based is both required. Examine symmetry or lack thereof. Not all progressive thinning is due to glaucoma. And these thinning of these layers can occur in 3 conditions which are common in all our glaucoma patients: hypertension, diabetes, and chronic kidney disease. So yes, your machine can also give you fake news. Thank you.
Yeah, thank you, Dr. Sanjay. Now, just 2 quick questions if anyone has from the audience.
Hemianopia that you were describing, how to pick it up early and like how to not miss it?
Well, if you see that kind of asymmetry in the macular thickness and the RNFL thickness, and then of course you see it on the visual field, most likely that is a chronic, that's a slow growing tumor. The patient has had structural loss but not had any symptoms. But it's very difficult to pick it up early unless you keep your antennas up when you see this extreme asymmetry.
Because what we get is when we get an altitudinal defect, that's when we have, retrospectively that's when we look onto these after looking at the field. So ours is like the opposite. We first get the field done and other things, and then if the field shows something, then we look.
Yes, definitely. That is
and the macula.
Definitely, the field is the first to go in homonymous hemianopia or brain issues, where you can see most of the time when you get the field, you're not going to get a clear-cut vertical defect. You're going to get some loss here and some loss here.
Some patchy, yes.
In the past, we used to have paper visual fields. We used to put them on top of each other. We have lost that ability now. So we have to imagine mentally to put them one on top of the other.
Sir, Dr. Sanjay, you showed a patient with RNFL defects without cupping. So what was the actual diagnosis in that case?
Hypertensive retinopathy.
Hypertensive retinopathy. Okay.
So but there was no exudates there. So how will retrospectively analyze that this is because of exudate or because of this damage?
You're absolutely right that it is in the absence of noticing cotton wool spots in the past. I also diagnosed these with as a glaucoma. It is only now that I'm realizing that many of these are not necessarily glaucoma. And now I am just doing a study which is near completion to identify on OCT what is the finding that can identify that this is coming from an old cotton wool spot and not glaucoma, which I'll be sharing next time. Thank you.